of physicians who are Black. So they can't take care of all the Black population. So as white caregivers, we need to do a better job of caring for minorities.
That's an excellent point. Does anyone else on the panel have any other input that they would like to add to this question?
Hi, this is Alona. Just a quick observation. You know, racism is a learned behavior. We're not born being racist. And when we look at systems and institutions, this is trickling down from what people have been taught from in their families, within their communities. And so it's important that we look at ourselves and we examine our own familiar structures as we move through other systems and take a look at the system we're working in and say, oh, am I being biased in some ways or racist just because someone had mentioned that, you know, they're comfortable with their own kind. And we know that that's a problem.
That's a very valid point. This goes along, there's a question posed on the chat, and this goes along very smoothly with what we are discussing right now, because we've touched on the same race treating the same race of patients. So Eva Stone asks on the chat, do the same disparities show when APRNs are providing care as far as outcomes and race?
I'm not on the panel, but I would like to take that one. I am not on the panel. I want you to know that before I came to the Kentucky Nurses Association, I did some work in the state of Kentucky as a deputy secretary for the Cabinet for Health and Family Services on undoing racism, and looked at a lot of data of healthcare professionals. And what we found is that healthcare professionals that are trained in institutions where most of the instructors are primarily white, they learn the same things as the Caucasian instructors in terms of unconscious bias, unless somebody helps them to relearn that. And so the real issue is our healthcare education system, where we haven't built in sensitivity to biases and awareness of unconscious bias. So because I am an African-American nurse who's caring for an African-American patient, if I haven't learned to be conscious of my biases, if I have not learned to be conscious of implicit bias, if I have not learned these things, I mean, if I have not unlearned them, I should say, because I did go to the University of Kentucky, and in my curriculum 40 some years ago, there was no special care and training for nurses to learn about biases. And I'm not sure that that exists today. And I'm not sure that it exists in many programs, in nursing programs across the spectrum today.
I'd like to add to that as well, because when you watch the movie, you see that a lot of laws and regulations were put in place to make healthcare equitable, and not equitable, equal. And you see that everyone had equal access, but the disparities for minorities continue to widen. And it was because it wasn't equitable. So with that being said, why isn't it equitable? Well, that goes back to what Delano was saying about looking at implicit bias. When you look at training of healthcare providers, all healthcare providers, there is limited resources and training available to them to learn about cultures outside of mainstream culture. Therefore, when they go out into practice, when we go out to practice, we only know how to look at things from one perspective. I do a lot of research on this particular issue now, and I'm training a lot of providers. I call it intercultural development. We have to learn how to work between cultures with each other, and we have to be able to see those differences. And so the thing is, we see the similarities and we try to make everyone the same. We also see the differences, but we ignore them because they're difficult. But we need to be able to see the differences within cultures, because that's what we have to treat in order to lessen those disparities.
I think a good example is I heard a woman talk about how she went to her healthcare provider, and he was talking about some symptoms that she was having, and the provider said, well, you know, a lot of Middle Eastern people have those kind of symptoms, and she was like, I'm not from the Middle East. And I think that you know, that is that implicit bias that we're talking about. Just by the way someone looks, you assume that they're from another place or another culture, and then we decide right off the top, well, you know, then it's okay that you're having those symptoms. Or I want to say also too that, you know, we need to pay attention to things like, you know, why do people of color lose limbs more often than white people? You know, we're more likely to offer amputations to people of color than to, you know, try to save their limb and do wound care and things like that. Well, why is that? Again, that's part of, you know, our biases, and we need to think about why we're offering limited care or these treatments that affect people's lives, you know, forever. When you lose a limb, your life is affected forever. So why are we doing that more for people of color than we are for white people? And those are just some of the biases, you know, that we have to start thinking about.
Yeah, one of the things I'd like to add to that, patients of color, I mean, the research shows, has shown us that they're more likely to be blamed for being passive with their health care. You hear the word non-compliant with people of color, and I think that, Teresa, goes along with what you're saying. You know, are they going to take their medications? Are they going to go to, and I think there's a bias there with that. But and I have seen that, you know, in my own practice. I'm like, how do you know they're non-compliant? You haven't even talked to them. You know, so I think we've got to go back, is that number one, we have to acknowledge that there is bias. We've got to educate ourselves and others. And one of the words I want, we're going to have to own it. If we're going to if we want changes, we have got to own it as a profession.
Thank you for making that point, Dr. Betty, because I was talking to a colleague this week who was telling me that one of her African-American patients was termed non-compliant. And the reason why is because he was eating bologna, and he's a heart patient, and bologna is high in salt. And so as we were having the conversation, she said that the person that was the provider that was stating that the patient was non-compliant didn't understand the social determinants of health, didn't understand that this person was poor, and that a pack of bologna is cheap and it would stretch out. And so it wasn't that the patient was non-compliant, it was that the patient was surviving by any means necessary. So I think it's important that when we look at our biases, we have to understand that we all don't live the same, we all don't look the same, and we don't have the same life experiences. So I thank you for bringing that to the forefront, because that just reminded me of that conversation. We have to talk to people. It's about having a conversation, a reciprocal conversation, to find out what their needs are in order to improve healthcare for minority patients.
Again, Judy, I am not on the panel, but I feel like I need to have a little say here. The American Nurses Association did a series of shorts on disparities in healthcare. There is a 7-minute short about a young man who got COVID and how he was treated and how he almost died because of how he was treated and how he was seen as a typical Black person. So if you get an opportunity to go to YouTube and look at that video, it's only 7 minutes, but it's well worth your time. And it brings all of the things that Dr. Benton Lee and Dr. Betty are speaking about to the forefront. in this one particular case. And I have to give a shout out to ANA because Dr. Grant is on too, and a number of my other colleagues like Cindy and Elaine. Thank you guys for being here.
One of the other things
Question.
that this film kind of brought up for me was, we hear a lot of people who take herbal medications and treat, things, my grandma gave me this, or her great grandmother gave her that. Well, is it because that's the only healthcare that they were allowed? Because, as white caregivers, we kind of kept them out of healthcare for so long. And I never ever thought about that until I watched this film. So when people, tell me that they take this herb or that herb, I'm going to ask a lot more questions of that instead of just blow that off and say, oh, you shouldn't do that. So I think things like that, that's an implicit bias that I had, and I have to think about those kind of things. We all do, but it just every day, it's just very eye-opening.
This is Dr. Kuiper. Dr. Grant, I wanted to ask you a question.
I can't let him talk.
Oh, okay. Well, I'm
Okay.
disappointed.
Yes, please. Hi. I was going to say she's controlling the who talks and who not. So
Yeah. I just have a quick question for you. With Medicare, Medicaid, and all that, do you think that's making a difference? Do we think that Medicare, Medicaid is making a difference?
I think it did, and but given the way that healthcare is going right now, it still is making a difference, but not as I think not as much as it did, say 20, 25 years ago, 30 years ago. And part of that, I think, is because of a lot of the payees of healthcare, of Medicare and Medicaid and et cetera, they don't feel that they're getting their fair share. So therefore, they're cutting services and et cetera. So subsequently, the patient is suffering from that. But that's something I think in some of our initial talks with the Biden administration, we're going to see quite a lot of changes in healthcare. I'm thinking, or at least that's their initial plans right now, what they're hoping for. Part of that obviously will depend, as you know, on getting members of Congress to go along with what President Biden would like to have done. So it's, for now, I guess the short answer to your question is it is not, but I'm hoping and praying that the plans that HHS Secretary Designate Becerra has laid out and wants to do, we will see some significant changes.
Okay, thank you. Thank you.
I find it concerning too. A lot of healthcare providers refuse to take care of patients who have Medicare and Medicaid. That limits their access not only to health services, hospitalizations, but when you think about this concierge medicine, have you all heard of concierge medicine, where you pay out of your pocket a lump sum to a care provider and they are at your beck and call? So if you can afford to pay for a concierge doctor, that's great. You get great they call them up on the phone all the time. If, however, you have Medicaid, you have to go shopping around for somebody who will take care of you. So I see an issue with evolving healthcare and who gets access, who doesn't, the types of healthcare that are allowed. And I think we really need to think about that. I never thought I would be a Medicare for all person. I think it has a lot of faults, but I think it just may expand the kind of access and maybe quality that we all are searching for.
Thank
But
you,
those-
Teresa, and thank you, Dr. Grant. Did someone have something to share?
I was just going to say those systems in themselves are racist. It's systemic through the government insurance companies themselves. If the reimbursement is so low that, and you said earlier, Black physicians primarily took care of Black patients. I ran a medical practice. My husband was a primary care physician, and it was difficult to live on that type salary with that low reimbursement. So it's problematic. The systems itself, now that they privatize, it's even worse, and the concierge have made it worse. So poor people, Black people, I mean, people who are not of the higher echelon will not get good health care in this system. Plus,
Very-
we need the resources in the communities too.
Very
That's your
good.
social determinants. I'm sorry.
Yes, very good point. Very good point. That leads us to our next question. Perfect timing. I want to pose this question to the panel. Is there a difference in your mind between equality and equity? And how do these definitions impact healthcare within the current United States system? Alana, do you have any insight on that question?
Let me think for a minute. No.
Well, while she's thinking, this is Dr. Kuiper. When I think about equality and equity, Delanor gave us an example a couple of weeks ago, but then I thought about people who run track and how they're on that oval track. You know, when you think of being equal, they all start at the same time and at the same place. And you would think that that would be equal and be fair to everybody. But we all know that the person that has the inside lanes, they have a shorter distance to run, do they not? So when you scatter them, scatter the runners, then you have equity. And you have to think about, you know, I think about disabled patients. They're going to, we're all going to receive the same care, hopefully, and stuff. But if we're going to have equal treatment, but equity, does that person have access to a wheelchair ramp? Do they have access for, to secure themselves when they stand? And that's how I look at it.
Very insightful. Does
I
anyone
want
have?
to draw everyone's attention to Donna Medder's picture. And I think I saw that first picture when I went to a talk with Marsha Hughes Reese some many years ago. She used that in one of her talks about equity and equality. And
there's also another one like that where it shows a person in a wheelchair.
Mm-hmm.
Yeah.
I think you also have to look at equity and equality as far as access as well. And the example I want to give is that minority patients have access, so equitable access to a pharmacy. But the equity piece is that the pharmacy may not carry the medications that they need. So they get discharged from the hospital and they need pain medications. And because their pharmacy in their neighborhood is high risk, they cannot get their pain medicine until the following day, or maybe until they drive, outside of the neighborhood to get it. So even though things are equitable, no, I keep doing that, sorry. Even though some things are equal, it's not equitable when you talk about access and ability to retrieve it. Right. So that's where I go back and forth. You have to think about the social determinants of health, and you have to think outside of your box and your bubble. Okay, I grew up very rural. I grew up in an area that was really poor, and I saw how healthcare impacted people. I saw home remedies, which people were talking about earlier, because they couldn't afford to go to the hospital. Hospital wasn't very far away, but they couldn't afford it. So access. So yes, there is a huge difference between equality and equity when it comes to healthcare. And a lot of it has to deal with access and those social determinants of health.
Very insightful. I'd like to acknowledge now, I think we've already answered this question, but we did have a Facebook Live question from Laura Blanco, and she is a nursing student. So I think that's great. She is wondering, as a future new graduate, what is the best way to educate herself about institutionalized racism and how to advocate for those affected by it. And I believe we answered that previously, but I just wanted to acknowledge her question before we move on, because that is important to all of us. And I think that we have recognized that, you know, there is a lack of education there that we need to fill the gap in.
Yeah, how I do that for the student is that, number one, we have to acknowledge it. We've got to be able to point it out. We have to be an example. We have to speak up, and we've got to individualize. You know, we can't treat people as a group anymore. We have to, and I hope y'all agree with me, assumptions get healthcare providers in trouble all the time. You know, they just like your patient, your person you was talking about, you know, he wasn't, you know, he could only afford the bologna, but he was being criticized, you know, and but like I said before, point it out, be an example, speak up, and individualize. And like I said, we've got to acknowledge there is an issue. And I had a person one time said, "Oh, in my hospital, we don't have racism," and I'm like, "You don't have a clue." You know, you don't have a clue what you're talking about. So that's just my viewpoint.
Thank you very much. All right, the next question that I have comes from Dr. Grant, and the question is, do we have any documentation for how other minorities were treated, such as Native Americans or Asians during this time?
Is it documented?
Yes, do we have any documentation for how other minorities were treated? Does anyone have any knowledge about this?
Yeah, there's plenty of documentation that, particularly when, you know, people from Asia were brought and helped build the railroad system here in this country, how they were mistreated, and they, you know, weren't given adequate health care. And even now today, you see how natives, you know, don't have access to healthcare. They have to drive hours and hours to see someone who is off of their land. So there's plenty of documentation of that. It would be nice if it was all wrapped up in a nice little documentary like we just watched. And hopefully somebody will do it. But yes, there is documentation of how these populations lack adequate health care.
Teresa, this is Ernest. The main point of my question, I agree with you that there is documentation, and mostly when you think about that, particularly for Asian Americans, it's on the West Coast. But I was thinking, you know, like around the same time, and you know, the Southeast, when you think of you know, what few Asians that may have, or Asian Americans that may have been in the Southeast at the time, or when you think of Native Americans as well, you know, is there any documentation specifically for the South? I guess I should have been a little bit more explicit with that, as opposed to, yes, we know about
Yeah.
you know, the West Coast, and you know, and all that, but it would just be interesting if anyone had any information about that.
I personally don't know. Does anyone else on the panel?
I do not. That's a great question, though.
That is a great question. Yeah.
Eunice put an answer in the chat box. Do you see that, Judy?
Yes, Eunice Taylor put an answer in the chat box and she says, I believe there is information and documentation. If you check the Native American tribes, you find information. All right, so moving on, the next question is, what solutions do you think can address unconscious bias in healthcare? So we've discussed quite a few of those already, but let's pose that as a specific question and let's start to begin the process of addressing unconscious bias. So what do you feel specifically we can do to improve this?
Alona, I think you've started answering that a while back, did you not?
I did. Fix the system. Oh, I'm sorry. It starts in the home. It really starts in the home.
It starts in the home.
If we start in the home and move it through our educational systems
I think
and teach
also,
our students to speak up and advocate.
I think you're right there. I think a lot of times, particularly, I think older individuals think of like their healthcare providers, their doctors as a person who knows everything. So I'm going to do whatever they tell me to do. But I think that we have to get to a point where we have to call out these biases that we see that are aimed towards us. And our, healthcare providers are not gods. They do make mistakes. And the only way they're going to learn is if we call it out when we see it.
Mm-hmm. There's two terms that I keep coming across, and it's called habitual replacement, that we have to replace habits. I see you smiling, Dr. Bentley.
Yeah. I think that, and I'm going to say this jokingly, but, we can teach our students and we can teach the kids and we can teach the patients, but we have to do something about the old and crusty. Okay. So we need to make sure that we're providing some developmental training of our providers. And we need to start with pre-licensure. Absolutely. There is not a pre-licensure program that I know of that offers intercultural development, or maybe they'll do a vulnerable populations class, but there's nothing specific to training them as providers to provide care in an unbiased way. So we need that. We need that for pre-licensure students. But for those that are practicing, those of us that have been practicing a while, that need change, I feel like we need to say, this is the bar. This is a training you have to have. I always talk about with the Kentucky Board of Nursing, we all had pediatric head trauma. We all had HIV. We all need implicit bias training. It should be a required CEU that we all take to be able to get out the old and the crusty. So I feel like we need some efforts on both ends to be able to make some improvement. But you're right, we have to do some community efforts. Teresa, my grandparents was those people, whatever the doctor said, they did. My grandmother took the same amount of insulin every time, regardless of what her finger stick was. And so we have to do some training there. So we have to kind of hit it at multiple areas. But I'm heartbroken by the student that asked, how can she do self-development? We should be providing that to her. And that breaks my heart. If you go look at textbooks, there's a few textbooks that are out there for vulnerable populations, but most of them are old, 2012 or later. Mm-hmm. And then they don't address how to interact with people. And we need to have that component. How do we have conversations? Right. How do we interact with people who look and act and think differently from us? How can I respect you and your culture? How do I incorporate your culture in your healthcare? Part of my culture was to take the placenta home after I had a baby. The nurses fought me tooth and nail over my placenta. I'm like, it's mine, give it to me. So how do we incorporate culture into healthcare? And so I think we have to hit it at multiple angles.
If I may contribute to the conversation, a couple of things. One, I personally have written letters to publishers of textbooks and asking them to to look at what they are putting out and and to address this issue. And that's going to start to change too when it comes to the NCLEX exams and et cetera, as students learn that. The other thing I wanted to share with you is just last Friday, the American Nurses Association, I actually have convened a national commission to address racism in nursing. And we have invited all the minority nursing organizations, as well as, like the NLN, AONL, and, AACN, and et cetera, to be at the table. And the way we're going to look at this is to address this sort of like the scopes and standards of practice that, books that ANA puts out. It's going to be in that fashion. And the reason why, because we wanted to specifically address education, clinical practice, research, administration or leadership, however you want to call that. And, so that it's across all those domains, and it would get accrediting agencies like the NLN or the Joint Commission or even our own magnet, certification to adopt those standards, and subsequently we get facilities and places like that to do that as well. So it's going to be a long time, before that document comes out. But we are, in the meantime, we'll have several white papers and things, put out, as we make progress. But I'm anticipating that probably maybe by this time next year, we may have a draft document that will go out for comments and et cetera. And in the meantime, we will be having, listening, programs, for nurses to give their experiences and things, because we want to make sure we incorporate all that. And of course, we know there's no way we can probably embrace everything, but I think the best approach that we thought about, putting it as a scope and standards of practice, because those do drive across all the domains, where nursing may be felt or addressed, is the best way to do that, because it's going to be the only way to make sure things are adopted, if you will, to ensure success, as opposed to just putting it out or saying, like everybody else who's in the DEI space is doing. This is above that, which would, I think, have some teeth. So I'll just throw that out. And if we are looking for folks who may have, content experts and et cetera, in that. So if anyone is interested, please let Delano know. And when we get down to the various subject matters, if you'd like to participate in some of the work groups, we would welcome your input. Thank you for the opportunity to speak.
Thank you, Dr. Grant. And I would also encourage you all, everyone that is on the discussion tonight, this last question that we posed brought about a lot of comments in the chat. So I would encourage you, as you're listening to the progression of the discussion, to also look at the chat box, because there are some really good solutions and answers for how we can improve this problem that we have regarding implicit bias.
One thing I want to say too is somebody said something that really struck me, is we try to tell people that they're not asking the right questions of the diverse populations that they take care of. But we're not asking, why are you not asking the right questions? And I think that goes along with implicit bias. It really struck me that, we can say, why are you not asking your patient who is maybe a Black man, if he wants to go home and do wound care and try to save his limb, but you're not asking yourself, okay, why am I not asking this patient, but I'm asking a patient who is a white patient?
Yes, absolutely. So we've had such a wonderful discussion tonight. We're probably getting near the end of our allotted time, and I have one final question that I would like to pose to the panel. How can we all be better at delivering healthcare through a lens that magnifies inequalities, recognizes that bias impacts our care delivery, while being intentional to limit the impact of our own implicit bias?
I think the first thing we have to understand to acknowledge is to understand or express why we went into the profession in the first place. We were here to help everyone. We weren't just selecting out. I think we just, we've committed to this profession, and we need to ensure that we're providing the best quality care that we can, and ensure that our colleagues and everyone else is as well, to all people.
I agree with that. And I think this is where mindfulness comes in also.
And I have to say about that, I hear a lot of nurses say, well, I'm just a nurse. Well, we have a lot of power as a profession that has 4 million people in it. And we're the most trusted profession. So if anybody's going to make a change in this area, it must be nurses.
Yeah. I agree, Teresa, but one of the questions I was hoping that we would get to talk about is, why do people of color not trust healthcare, the institutions? Why do they not trust their individual physicians? And one of the things that keeps popping up is, number one, I think sometimes they get embarrassed. They're not treated with dignity. We've got to counteract the stereotyping and treat people individually, listen to them, stop making assumptions about who they are, what they are, where they live. Health literacy, we have been talking about that for years. And why does a healthcare provider make the assumption that people of color are not educated? That's one of the things that just burns me up. It's like, what do you mean? You haven't talked to them, and so I think, again, we've got to go back to that acknowledgement, owning it. And I agree with you. Our profession is so powerful that, this is something we're going to have to take on and follow it through. Just not talk about it for a few years, but follow it through.
I tell my students all the time that my stance here lately is be healthcare reform in action. So if you don't like it, be healthcare reform in action, meaning you make the change. And so I think that a lot of us did go into nursing because we wanted to make a change. We saw things differently, and we wanted more so not to be, to be nurturing, but also to make an impact. And so as we move forward, we need to be able to do that. And then to go back to Dr. Betty's point of, why is there not a trust? It is longstanding trust. It is many, many years. It is Tuskegee. It's the Henrietta Lacks story. It is stories of people going into the hospital, fairly normal, and then coming out in a casket. Those are generational. And so those stories are passed down generationally. And so I carry those stories, and other people carry those stories. And so when we go into the healthcare facility, we go in thinking that we're not going to get the same level of treatment as someone else. And so we have to change that. We have to change it so that people feel that they can come in and have a conversation and that they're going to get the same healthcare. But another thing I wanted to say is that research says that for people of color, in order for them to trust their healthcare provider, they have to have a relationship with them. And the way our healthcare system is set up, it's in and out 5 minutes and you're done, and they can't build a relationship. So it's very important that we take steps to build relationships with people of color, because once that relationship is established, then they're going to be more forthcoming with their conversation. And they may even bring mom and sister and aunt because they feel like they're getting the care that they need. So we have to look at healthcare differently. We have to be healthcare reform in action.
Well said.
Yes, very well said.
I agree.
I agree. I agree.
So I think that we are moving into final comments. And is there anyone on the panel who would like to add any final comments to this wonderful discussion that we've had tonight?
I just want to say thank you to everyone who is attending. This was a project that was given to me to write up, and I think that it's a great way to have good conversations, but I also want us to start thinking of solutions. There's been a lot of talk for a lot of years. And so now we need to start thinking about how are we going to stop talking and start acting.
Exactly.
I agree.
Yes, very much so. Excellent discussion tonight. Delanor, would you like to say a few final words?
I would. I also like to say thank you. We didn't get the 3,000 people that I anticipated. However, we were ready. I just want you to know. I want to say thank you all for coming in, and particularly to the panel, for you all turning on a dime and putting everything on hold so you could be with us tonight. We will continue this series next month, February the 25th. We will have a movie night. It'll be Incarcerating Us. And then again on March the 25th, we will look at Cooked. And so we will continue this series until June and evaluate whether we want to continue that going forward. So if you would like to send me an email and tell me something about something other than having to wait in the waiting room, I'll be glad to listen. The waiting room issue is resolved at this time. But I also want to say thank you to Kimberly Buckner, because without her, we would not have been able to do our Facebook live streaming to accommodate the 3,000 people we thought were going to come today. So we're looking for suggestions for other movies that we could review and discuss. And we hope that you will join us for the next 5 of our movies that we will have in this series. I'd like to offer Donna Metter, our president, a moment to say something and close us out.
Well, I want to just thank you guys who put this together. This was amazing. I learned a lot, and I think probably everybody on the call and watched the movie learned a lot, more than we expected to learn, really, probably. So I want to thank you all for your time on a Thursday evening, and for the panel for sharing your insights and your wisdom. Thanks to Dr. Grant for being with us tonight, and thanks to Delanor for putting all this together with the help of Teresa and the rest of Judy and the rest of the folks who planned it. So thank you all very much, and we kind of know we need to be thinking about some action. So move forward. So next month will be interesting. We'll hopefully see where we've come from in a month.
Great. I want to remind everybody to go to look at the movie first and then join us for discussion afterwards.
Okay.
Thanks,
Thank
everybody.
you.
Thank you all.
Bye.
Bye.
Bye, y'all.
Thank you. Thank you.